Hello, my name is Michael Brennan. I am an endocrinologist for the Beaumont Health System. I was asked to present to the Greater West Bloomfield Chamber of Commerce virtual event for 2020 about diabetes. And the topic that we'll be discussing is what's new in type 2 diabetes. We're going to talk about type 2 diabetes because it's the most prevalent form of diabetes. I am the director of the Beaumont Endocrine Centers, as well as chief and section head of endocrinology at Royal Oak, Michigan Hospital, and for the health system in the Beaumont Medical Group. My hope today is to educate you about what type 2 diabetes is, the prevalence of the disease in the population, and I'm going to give you some suggestions for how to treat type 2 diabetes, because there are some major changes in the last decade, maybe even the last couple of years, with regard to cardiovascular disease health and type 2 diabetes. I hope you find this informative. I hope you understand that we have several endocrine groups in the Beaumont Health System here to serve you, and we want to help you with your diabetes. I also encourage you to talk to your primary care physician if any of these medications or things are available for you. Obviously, in all cases, all these medications might not be available for you because of other comorbidities or other ailments. So please review with a physician or a clinician or a nurse practitioner or a nurse or a pharmacist or a physician assistant before making any clinical judgments or decisions on your own, okay? So today's topic is type 2 diabetes, what's new with type 2. With regard to resources, there are resources available for you. Diabetes Care makes an annual standards of medical care in diabetes. This is available for free online. We'll go over some vital statistics, which is available generally through the CDC. There's another resource that's very nice at www.aace.com. This is the American Association of Clinical Endocrinologists. This is a very simple algorithm with regard to looking at diabetes, if you might find it helpful. The objectives of today will be to understand type 2 diabetes and its pathophysiology, because that's what helps us determine how to treat type 2 diabetes. We'll describe newer classes of medications that we need to know and the current approaches and strategies. Just so we understand what we're talking about, diabetes is actually a small portion of what makes up the leading causes of death in the United States for both males and females. Heart disease and cancer are more common in the elderly. With regard to the young, unintentional injuries, etc. But the problem is that type 2 diabetes increases your risk of heart disease. And so therefore, in treating diabetes, we're also treating heart disease and stroke depending on the agents that we use. We also know that diabetes can lead to several worsening of what are called comorbidities or illnesses, such as eye disease, kidney disease, and foot disease. This all stems from obesity. As we look at the map of the United States in 2018, there's not a state in the union in which the prevalence of obesity, which is defined by a body mass index of 30 or greater, is not 20% of the population or more. If I were to show you the same image of the United States in 1993, there would not be a state in the union in which there is any obesity greater than 20%. People say to me, Dr. Brennan, how does this happen that we become obese, so obese over the last 20 to 30 years? There's no easy answer to this. They talk about hormones in the milk. They talk about high fructose corn syrup, lack of sleep, screen time, all of these things. There's something also called the thrifty gene hypothesis, meaning when we get excess calories, we want to hold on to them and bulk up for pandemics like COVID or shortages of food and supply. So whatever the reason may be, we don't know, but it's probably an amalgamation of all of those things. Type 2 diabetes is the most common form of type 2 diabetes, accounting for 90% of the cases. There's also this one type of diabetes called type 1 diabetes, okay? And we'll talk about that more. But type 2 diabetes is hallmarked by being somewhat overweight and having insulin resistance with a positive family history occurring in people over age 30. Insulin resistance is the hallmark. And why is that important to understand? That's important to understand because it means that you have insulin in the system. It's just the cells receiving the insulin are resistant to it and not working so well in resisting the insulin. So we need to, if we can stop the insulin resistance, then we can in turn change the diabetes around. Type 1 diabetes is defined by not having any insulin, okay? And just for personal note, the reason I'm so passionate about diabetes is because I have type 1 diabetes. Now, my solution will not be solved by decreasing insulin resistance. I have to take insulin in order to take care of my diabetes. Type 2 diabetes can be solved. It doesn't mean that you don't have diabetes. It's just where on the spectrum do you fall? Do you have type 2 diabetes insulin resistance that can be controlled with diet, with pills, or maybe sometimes with shots? Just as we age and sometimes we need bifocals, sometimes we need hearing aids. These are not bad things. Sometimes if we're really lucky, maybe we'll need a walker because we lived long enough. Similarly, the beta cells, which are the cells that make insulin, don't work as well. Similarly, the body gains insulin resistance over time. So we hope to treat those things. Now here's something fascinating about type 2 diabetes. Generally speaking, the pathophysiology of this insulin resistance begins 10 years prior. I hope that you can see my cursor, but at year 0 is the diagnosis. But pre-diabetes and type 2 diabetes are generally happening 5 to 10 years ahead of time. And during that time, insulin resistance is increasing, therefore insulin secretion is increasing, and beta cell function, which makes insulin, is decreasing until a point of failure in which the insulin secretion can't keep up with these blood sugars, and the blood sugars rise, and the doctors detect the diabetes. Now, ideally, we would decrease insulin resistance before that or at that time, and then have adequate insulin stores for the rest of our lives. So that we understand diagnosing diabetes, it's defined as a hemoglobin A1C greater than 6.5%. But pre-diabetes is diagnosed by having an A1C between 5.7 and 6.4%. A fasting blood glucose greater than 126 defines diabetes. If you were to have what's called a 75-gram glucose challenge and your blood sugar goes above 200, that would be diabetes. Pre-diabetes is defined by the similar test of the 75-gram glucose challenge going to 140 or 199. And if you come to the hospital and have weight loss, lots of thirst, lots of peeing, this might be diabetes as well, especially with a glucose greater than 200. Again, to understand the prevalence of the problem that's been happening over the past couple of decades, here's an example of what the prevalence of diabetes looked like in 1994. Again, no state in the union has greater than 5.1 to 6.4% of the population having diabetes. But then we fast forward to 2014, and no state in the union doesn't have more than approximately 6.5 to 7% of the population in each state have diabetes. Again, I can't explain exactly how that occurs or why that happens, but it does happen, and we're dealing with it today, mainly again through obesity, its effects, our aging, etc. And just so you understand, the percentage of people in Michigan in 1994 that had diabetes as a whole population, including all the children and all the adults, was 4.9%. And now in 2014, it's at 9%. For people over age 65 in the state of Michigan, 25% of them have diabetes. And in 2016, which is essentially the most recent data from the CDC, it essentially looks the same. Again, this highlights the 25% that was seen in ages 65 to 74, meaning 1 in 4 people in this age group has diabetes. And from age 45 to 64, 13% as of data from 2014. A lot of people put weight and measure on this thing called the hemoglobin A1C. What this is the sugar coating of a red blood cell over the past 2 to 3 months. Why is it 2 to 3 months? Because the red blood cell lives on average about 3 months. So therefore, you can check the hemoglobin A1C every 3 months to see how sugar-coated it is and make an average estimate of what your blood sugar was. This chart helps explain that. The goal for most data with regard to when diabetes gets worse or better is based on the fact that when the hemoglobin A1C was 7% or less, we didn't have what are called microvascular complications. That means eye disease, kidney disease, foot disease, okay? And an A1C of 7%, which you don't have an A1C machine at home, you have a blood sugar tester at home. A1C of 7% correlates with a blood sugar of approximately 150. So when your physician says, I want your A1C to be 7% or less, what they're really asking you is, I'd like your average glucose to be 150 milligrams per deciliter or less on average. Now, we know that you're going to have cake on your birthday and it's going to go high. We know that you're going to have some days that the blood sugars aren't well controlled during stress and other things. But on average, we'd like it to be 150 or less. Ideal range probably between 60 and 150 approximately. And what's your goal? Most people say a goal of 7%, but let me give you an awful example of when it shouldn't be 7%. Like for example, if you had stage 4 pancreatic cancer and you knew your life expectancy was short, then you would not shoot for a goal of 7%. The goal of 7% is when your life expectancy is long, greater than 20 years, greater than 15 years. Because it's the long duration that causes that microvascular effect. Having uncontrolled diabetes, long duration is the problem. So in patients, unfortunately, that I've had who've struggled with stage 4 malignancies and things like that, that have diabetes, I don't tell them not to watch what they eat because their life expectancy is short. Therefore, there are different times and different things depending on life expectancy, disease duration, other things. Maybe you can't handle having well-controlled diabetes because your chronic kidney disease makes it hard for you to metabolize the medicines. There's a whole host of variety of reasons why the A1C might have to be different for each one of you, and that's for you and your physician to discuss. But where would we like to stop diabetes? I would like to stop diabetes from ever happening. I'd like to maybe do it before the diagnosis. We certainly don't want to wait until death. Maybe we could intervene when the blood sugars are just a little bit high. These are all options. And where you start is kind of the art of medicine. The red circles are your red blood cells, and the white circles are your white blood cells, and the brown circles are donuts. We need to have a talk. Yes, you do. Please discuss it with your doctor. We can now try to stop diabetes by choosing complementary agents, not just treat the A1C. Early treatments with the right types of medication that decrease the insulin resistance can therefore save beta cells or insulin producing cells and then stop or reverse diabetes. We call this egregious 11 ways in which type 2 diabetes hurts the body. I won't go into them in detail. You can look them up further if you want, but type 2 diabetes isn't simply just an insulin problem. It's I'm not feeling full all the time because I have insulin resistance and my brain doesn't understand fullness anymore. There's problems with insulin resistance in the liver. There's problem with the insulin producing beta cells failing. There's insulin resistance in the muscle. We have a whole host of ways in which to treat this disorder now along all of these. Now, the first and foremost medication for type 2 diabetes is always to try lifestyle and weight loss modifications for a little bit. But we know that is hard. If it was easy, we would all do it. Then the next medications, because we know that it's cheap and we know that it's very effective, is metformin. All of the approaches to type 2 diabetes start with metformin, and once the beta cells run out, end with insulin. But there are good choices in the middle to choose for type 2 diabetes that can help you with cardiovascular disease as well as those microvascular complications. Those drug classes that are important for you to understand are called glucagon-like peptide 1 receptor agonists and sodium glucose transporter 2 inhibitors. I'll explain those further in a minute. Again, everybody begins with metformin and everybody ends with insulin. With regard to these things, I'm going to refer to the glucagon peptide 1 receptor agonist as GLP-1 and the sodium glucose transporter 2 inhibitors as SGLT-2. Okay, moving forward. These are classes of medication, and therefore there are individual drugs underneath each one. I will explain. Metformin always first, but over time rarely controls the hemoglobin A1C. It has to be monitored carefully with your doctor if you have poor renal disease because of the concern of this condition called lactic acidosis. It's weight neutral and sometimes weight losing. And it usually has help in several of those ominous octet or egregious 11 methodologies of hurting you with type 2 diabetes. And the estimated A1C loss is approximately 1%. Now, in 2008, the Food and Drug Administration said, we need to make sure not only are we stopping the microvascular complications, we need to stop the cardiovascular complications, because people with type 2 diabetes are 2 to 3 times more likely to have heart disease and stroke, and a lot of people die from heart disease and stroke. So they opened up these things called for major adverse cardiovascular event trials. They are related to outcomes with regard to death or injury due to cardiovascular death, non-fatal myocardial infarction, which is a heart attack, or non-fatal stroke. These trials were powered differently and observed over time. They took thousands of people with diabetes, treated them aggressively with aspirin, statins, which are those things that lower your cholesterol, blood pressure medications, and treated their type 2 diabetes aggressively. And they did the same thing in the other arm of the study, but they gave them these new classes of new medications and see what happened. They do this for all medications moving forward for type 2 diabetes, thanks to the Food and Drug Administration. And the only classes of medication that have shown outstanding results with regard to improved cardiovascular disease are these things called the SGLT2s and the GLP-1s. So again, the people receive standard of care in one arm plus the new medication, and the other arm receives just standard of care. And we wait to see what happens. Just so you know, chasing the ice cream truck does not count as a summer fitness program, though several of us like to do that. The names of the medications in the SGLT-2 inhibitor class you've heard of possibly before. They end with this suffix called gliflozin, conagliflozin, dapagliflozin, pagagliflozin, erdagliflozin. They also go by the trade names that the drug companies have called Invokana, Farxiga, Jardiance, and Steglerio. Now, these medications take care of glucose by eliminating glucose in the urine. So if you have some kidney disease, these might not be the best medications for you. There's questions about, do they increase risk of yeast infection? Also this condition called Fournier's gangrene and amputation, though the Fournier's gangrene and the amputation are not very often seen and are not yet attributable to this. With regard to its advantages though, when you're peeing out extra glucose, you're peeing out extra calories, and therefore we see weight loss. With regard to cardiovascular disease in those MACE trials, it was decreased. People with congestive heart failure did better, and people with renal disease did better. So these are amazing things, and they cause weight loss, weight reduction, and a 1% decrease in A1C. So all three of these medications in this class showed improvements in MACE trials and cardiovascular disease, congestive heart failure, and renal disease. Sorry, my computer tried to interrupt us. With regard to how can this be? How can SGLT2s and cardiovascular disease be affected by peeing out glucose? Well, it turns out, for a more scientific discussion, that these things change blood pressure because they act a little bit like a diuretic. They improve how your heart functions because of that change. There's things called fibrosis and necrosis that are limited by having this medication, because it turns out that the same receptor is in the kidney called SGLT2. There's also SGLT1, and those are in the kidney as well as the heart. And we think that they may be working together to help us with heart disease as well. So studies are underway for this medication, not just to be used for type 2 diabetes, but possibly in cardiovascular disease alone without diabetes. The other class of medication that I wanted you to learn about was the GLP-1 class. These have the suffix of glutide, abliglutide, dulaglutide, exenatide, liraglutide, semaglutide, okay? These are equally interesting hormones that are produced by the gut. When you have type 2 diabetes, this effect of this gut hormone is lost. It's helpful too because it causes weight reduction and weight loss by making you feel full, which is also helpful in decreasing insulin resistance. This effect is called the incretin effect, which is the increased secretion of insulin effect. And what it shows us in this study is that you would think that by eating glucose, you would have more insulin secreted, which is the light, the dark blue line shows that when you eat glucose, more insulin is secreted than when IV glucose comes into your system through infusion. That part is somewhat counterintuitive. I may have misspoke. If I was to receive IV glucose, I would think more insulin would come out of my pancreas. But in fact, when you eat, more insulin comes out of your pancreas. So somewhere between IV infusion and eating was a hormone that was causing an increased secretion of insulin effect. And that hormone turned out to be GLP-1. And it also appears to have a cardiovascular benefit by stabilizing plaques, controlling hypertension, helping lose weight, and improving your lipid panel. Now, the FDA also says that it carries a black box warning for a problem called medullary thyroid cancer, which is a rare type of thyroid cancer, rarest almost of the rare. It's seen in families with what's called an autosomal dominant lineage, usually, meaning your brothers and sisters had it, one of your mom or dads had it, your children had this rare type of medullary thyroid cancer. You would know if you had this disease because it affects people relatively young. This medication caused medullary thyroid cancer only in rats. There's not been reported case in humans, but because of the rat data, the FDA wants me to make sure I talk about this and let you know, and so should your doctor if this medication is used. Now, that being said, it's only been seen in rats, not in humans, and we've been looking for the past 1 to 2 decades for a complication of this medication, and it's not shown to be true. So as I would treat my own mother and father, brother, sister, wife, children, this medication is safe, and we prescribed it lots at the endocrine centers. The FDA did those same MACE trials, and it turns out that these medications also had effects on major adverse cardiovascular events. Dulaglutide, which is Trulicity, reduced the risk of major adverse cardiovascular events in people who had high risk and also had type 2 diabetes. Victoza or liraglutide to reduce major cardiovascular events in adults with type 2 diabetes and cardiovascular disease. And semaglutide or Ozempic also reduced major adverse cardiovascular events in adults with type 2 diabetes and cardiovascular disease. Now, those 3 medications that I just told you all come in the form of a shot, either once a day or once a week. But recently, in the less than a year, they've managed to make this medication in a pill called Rybelsus, which is another thing to discuss with your doctor. Because if you were adverse to shots, Now you can get it in a pill. So you ask yourself, what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? Well, with type 2 diabetes, we don't have to go straight to insulin anymore. We have to start with metformin and figure out therapeutic agents that have long-lasting tolerability. They have a glucose lowering effect, but don't have hypoglycemia. Those agents that I just told you about, you don't really have to test your blood sugar very often because they don't make your sugar go low. They make you pee out the extra glucose, and they work when you eat. So they're not accompanied with hypoglycemia. They have weight reduction associated with them, improved blood pressure associated with them. They decrease lipids. They provide cardiovascular protection, okay? Little to no hypoglycemia. So after metformin, discuss with your doctor SGLT-2 therapy and GLP-1 therapy for type 2 diabetes. It's not just my opinion. Again, ACE and the American Diabetes Association suggest this. Here's an example. When your hemoglobin A1C is between 7.5% and 9%, you start with this drug called metformin, but then when you need 2 medicines or 3 medicines, the first 2 classes they talk about are GLP-1 and SGLT-2. They honestly talk about sulfonylurea, which is glyburide, glypiride, glimepiride. Those have warnings associated with them. So talk to your doctor about these new medications in the literature that help heart disease, help you control diabetes, have weight loss, do not have hypoglycemia. They're new and improved approaches to type 2 diabetes. Type 2 diabetes, in conclusion, is a very prevalent disorder. Once it's diagnosed, try and fix the underlying, what am I saying, pathophysiologic problem, or stop the insulin resistance, halt the progression of the disease, turn it around so that it doesn't advance. Don't treat insulin resistance with more insulin. Not the best idea anymore. Ask your doctor to be familiar with at least one drug from the following classes, the SGLT2 and the GLP-1. The management of diabetes is where the art and science and practice of medicine converge, right? Exercise, diet, those sorts of things. And giving great care to yourself and your patients as physicians is where you have long life without complication is the great reward in being a doctor. I hope that you found this interesting. I hope that you found it helpful. I hope you come to the Beaumont Endocrine Center. We have 3 locations in Beverly Hills, Troy, and St. Clair Shores. Please tell them that you heard of this discussion through us, call us, or go to any Beaumont endocrinologist. It's our pleasure to serve you. We're here for you in the great community of West Bloomfield. Please stop by anytime.